Hello and welcome back to Reinforcement Talking. I'm your host Maria, and today we have a very special guest joining us. He is a renowned professor of neurology at the Institute of Neurology, UCL, and an honorary consultant neurologist at the National Hospital for Neurology, Queen Square. Please welcome Professor Parashkev Nachev. Thank you so much for joining us today.
Thank you for inviting me.
Artificial intelligence technologies are believed to have one of the greatest ever impacts on healthcare. AI has significantly improved the accuracy of diagnostics, allowing radiologists to improve the detection of cancer, helping in drug discovery and generation of personalized treatment strategies, and assisting professionals in many other tasks. Today, we will be discussing how AI can move us forward towards personalized medicine and help in other domains of neurology and healthcare overall. So let's dive straight into it. Could you tell us a bit more about your work in the intersection between neuroscience and machine learning?
Yes, so I suppose I begin from the nature of the fundamental problem that all clinicians face, but especially neurologists, and that is the essential complexity of the system that we're studying. If you think about the process that generates human beings, it is, on one hand, fairly aggressively randomizing, because of course that is how genetic selection works, and on the other hand has to create organisms that are adaptive, and that means that they're bound to be both different from each other, but also configured in a way that means that they'll have multiple potential forms of operation, and therefore multiple potential forms of failure, which is of course what a clinician is interested in. So in order for us to understand these systems, what we have to do is to apply models of commensurate expressivity, complexity themselves. There is, I suppose, one of the few proofs in cybernetics is Ross Ashby's proof of the necessity of the controller, good control over a system, to be just as complex as the system itself, the law of requisite variety. And of course, that necessarily applies to medicine too. Now, the way that we have solved this traditionally has been to split medicine into two separate attitude or approaches to the patient. One is to try to do things intuitively, which means that the clinician absorbs over time experience about what works and what doesn't work, and then intuitively, often tacitly, so without actually being able to give a good reason, implements a treatment strategy. And then there is the objective, which involves using data from various observational or interventional studies as appropriate to try and guide the management. And the latter approach is, of course, what we always want. We want something objective. But the problem is that because of the limits on the tractable complexity of the sorts of models that we can develop in order to make these inferences, we have relied on highly reductive parameterizations of individual patients. So, for example, if you go and see your GP and ask about your risk of stroke, they will ask you about your age, whether or not you smoke, perhaps measure your lipids, measure your blood pressure, and then on the basis of those 4 or 5 parameters, issue some sort of prognosis. Now that's clearly, or some sort of risk stratification, now that's clearly far, far too reductive. And so what I've been trying to do is to find ways that combine the flexibility, the expressivity of a clinician operating intuitively with the rigor and the objectivity of a machine, of a system that attempts to make inferences objectively, and that is where complex modeling, or AI, whatever you want to call it, comes in.
That's quite interesting. Do you think if we use DNA, for example, to kind of gauge what sort of parameters might be applicable to different individuals, do you think that would be a possibility in the future? Like using genetics basically to help with determination of different diseases?
Well, of course. So we know that the way that a human being responds to the environment is inevitably going to depend on the constitution, and of course that is driven by 2 factors very broadly: the genetic makeup and the environment during development and subsequently. And there will be, of course, a genetic contribution. The critical question is, how do we model genetics? The current approach is to treat it essentially as a simple linear system where each individual genetic locus can be independently associated with an outcome. In recent years, that has changed a bit. People now talk about PRS, polygenic risk scores, that attempt to integrate multiple loci and to produce a prediction based on more than just a single genetic feature. But the reality is that even those sorts of approaches will be far too reductive. They may identify with fairly simple statistics what this relatively small number of features might be, and then they combine them together. And most of these predictive systems do not work as well as they could. What is needed, really needed, is a proper model of the genome. And the challenge there is to find what its intrinsic structure is. And to do that really needs hundreds of thousands, potentially millions of genomes and a huge amount of compute. And I think once we have that, once we have a better grasp of what is the essential dependence between distributed genetic elements in actually producing physiological outcomes, it's only then really that we'll be able to make good predictions from the genome.
I see. I've also read that you've done a bit of equitable modeling, and I was just wondering what it is and how this links to your current research, maybe.
Yeah, so this is an interesting problem. So whenever people talk about AI in healthcare, one of the things that is raised over and over again is that AI is biased, AI discriminates against subpopulations, and that its introduction will potentially cause harm in that respect. What I showed in a recent paper is that that's a misguided way of looking at things. The reality is that our task as clinicians is to achieve the best possible outcome for every patient, regardless of any circumstance. So, in effect, to give everybody the same opportunity to benefit from treatment. And that means that we have to define the scale of variation at which systematic differences in susceptibility to treatments, for example, or benefit from one intervention or another happens to vary. That means that what we need is not just to check whether or not a model or a treatment, anything that we do in medicine, is invariant to features of concern, such as age, sex, ethnicity, and so on. But what we need to do is to look at subpopulations that are defined by intersectional interactions between those features, and maybe many others. If a subpopulation happens to be defined by, let's say, age, sex, but also something like, I don't know, perhaps height, or maybe hair color or eye color, or something that is not traditionally registered, then if there is a bias with respect to it, then that is no less actionable than any other. What we care about is that every individual gets the best possible treatment. So what this means is that an essential component of any equity-promoting framework is the segmentation or the representation of the population in much finer terms than the classical protected characteristics typically allow. And so in order to generate those representations, inevitably we need complex models. So actually we need AI in order to be able to identify the space within which equity and inequity may arise. And of course, once we have identified it, in order for us to rectify any biases that have emerged, we need our models to take into account those variations. And that, of course, also means using AI. So far from being a risk to equity, AI is the only plausible solution. And now you might ask, well, hang on, are you saying the current methods are biased? The reality is that they're all horrendously biased, but we just don't know about it. And the reason that's so is because whenever you're treated according to the evidence-based that is, whenever your treatment follows guidance from the highest class of evidence, which is a randomized controlled trial, you're inevitably being compared not to someone like you in the sense of someone sharing your characteristics in the high-dimensional space that describes people's individuality, but you're compared against the average of the population, described on the basis of relatively few features. And what this means is that you're effectively going to be a poor fit to that inexistent average in proportion to your distance from them. So the further you are from the average of the population, the worse the fidelity of the model with respect to you is likely to be. So actually, the current approach is criminally biased, but people don't notice it because the way in which patients are characterized is too simple. And so it passes unremarked.
So it's a very, I think, very good and very interesting approach, but I feel like data sharing might raise some ethical concerns. And I was wondering how you think of like overcoming this hurdles.
Yes, so I mean, as everyone knows, in order to build complex models, you need data that's both large in scale and, of course, ideally fully inclusive. It needs to be able to sample the distribution as completely as possible. And that inevitably, doesn't require, but will benefit from aggregation of data. Aggregating data in healthcare is always going to be difficult because whenever you move a datum, there is the risk that it might go in the wrong place. And unlike, banking systems where if you lose some money, your bank can just credit it to your account. If you lose some information about your health, then there's really no easy way of erasing it. So we do need better systems for assuring the security of handling healthcare data. Can that be done within a data sharing framework? I think it's possible. It just requires perhaps more attention to the quality of the infrastructure that the NHS runs on, the digital infrastructure the NHS runs on, than we currently have. And it's partly a question of persuading the government to take that issue seriously. However, there will always be difficulties, and that's why there is a lot of work now on creating systems that allow us to train models without sharing data, so federated learning. Now, of course, that's not necessarily a perfect solution because you don't completely remove the risk, but you merely reduce it. It's always possible that some information might leak just through the process of updating a model from running it at multiple sites. So the federated learning process, where the data doesn't move, the models are essentially coordinated across sites, does involve some communication between models, and that might conceivably leak. But it's one form of protection that will definitely help. But I think the most important thing here is to think about why it is that we're doing this in the first place. There is sometimes an attitude, particularly in clinicians, that science is, particularly the pursuit of scale, is decoupled from the actual needs of patients. That this is something that scientists do, not quite for fun, but they do it in pursuit of their own objectives. And actually the benefits to patients are not obvious. The reality is that the only way of descending to the level of the individual, essentially doing what it is that medicine fundamentally needs to do, to treat the individual patient in front of the doctor, is by analyzing data at sufficient scale to allow for models of the requisite complexity to be able to be trained. And so we either adopt this kind of technology and take the risks inherent in analyzing large-scale data, or we won't be able to fulfill what medicine actually demands of us. So I think we have an option. It's a problem, but it's a problem we need to solve.
So, moving on to neurology, how can AI help improve patient outcomes in neurology specifically?
Well, I suppose there are commonalities with the rest of medicine. As I was saying earlier, the fundamental nature of human beings is they're complex, and so you need models that can capture that complexity. I suppose in neurology it's especially acute because the brain is so complex, but also exhibits a learnable organization. So it's a complex object. It is an object that we can learn. And perhaps the richest representation of the of the neurological aspect of a patient is imaging of the brain. And there, if you think about it, we acquire volume images of, depending on the resolution, potentially millions of individual elements. And each of these can be treated as an independent variable. And making sense of that extraordinarily rich pattern is something that one needs complex models for. But once you've trained a model to be able to absorb these patterns, then potentially we can create models that can, for example, predict outcomes or direct treatments with far greater fidelity than something far more reductive. And I think the crucial point here is that the real value of complex models is not so much to assist radiologists, for example, to do reductive tasks such as measure the volume of a lesion in the case of, say, a tumor or a stroke, but rather to parameterize the abnormality with sufficient richness to be able to then predict outcomes or treatments with individual level precision. So it's not really about assisting what clinicians do, but more about enabling the evidence that is brought to bear on a decision that's taken with respect to an individual to be properly aligned with what that individual needs. And that is a problem that is there across the whole of neurology. Imaging happens to be a particularly striking example.
So, I see that you mainly focus on basically AI assisting neurologists or other clinicians. But do you think it will ever be able to completely overtake the roles of medical professionals? And basically, you just, for example, type in the symptoms, type in your previous history, basically, and then AI can tell you what you need to do with, let's say, 90% precision, which is more than a clinician, I guess.
Well, so it's difficult, I think, to say anything general about that because it depends on the domain. I think in general, overall, I would say the diagnosis is probably the hardest thing that you can do. And the idea that a machine will be able to do it well, I think is probably fairly remote. Once you've established a diagnosis, once you've narrowed, at least a differential diagnosis, once you've narrowed the space of possibilities, then I think machines can be much more usefully applied. I have to say, skeptical that we will ever be in a position where a chatbot of some kind can be a replacement for a human being, not least because it's not just about the history, it's also about the examination, it's also about various aspects of the patient that cannot easily be absorbed into a model because you need to be there, you need to see, you need to touch, and of course you need to interrogate. Yes, large language models will soon enable automatic conversations between a kind of clinical automated interrogation agent and a patient. But again, I think for them to direct the questioning in the right way will always require some guidance from human beings. It's also worth bearing in mind that the problem that medicine tries to solve, which is to determine what's the best treatment for a given patient, is fundamentally insoluble in the sense that there will never be a perfect answer because each patient is unique, and it may be that they vary in a way that's material to the outcome. And of course, because they're unique, you have no reference by which to predict that. So you will always be trying to get better and better, and models will come into play in synthesizing the available information as well as anyone can do it. But there will always be an element of human judgment, just because it's very hard to justify relying on a machine, knowing that machines will never have the same flexibility as a human brain when you're testing them on as broad a problem as full space of possible diagnosis, which is a patient coming into a clinic or into the GP surgery presenting with a problem. So it seems to me that although some tasks may be performed at superhuman levels by these machines, the human being will always be in charge.
I suppose also that in case something goes wrong, someone has to bear the responsibility, and putting responsibility on the machines or the developers of the machine might not be quite viable.
Yes, I mean, people often raise that argument to say, but if the decision maker is a machine who is actually responsible. But the reality is there is already a model for that. If a piece of machinery fails, let's say, for example, it's a surgical instrument. If it fails owing to a manufacturing defect, then it's the manufacturer who's liable. If it fails because it's misused, then it's whoever it is that's misusing it that's liable. And I think the same framework will be naturally applicable here. So I don't think responsibility is the fundamental problem. I think the fundamental problem is the nature of the task that the clinician solves is such that it's very, very hard to entrust to a machine. Maybe one further aspect to think about is this business of knowing when you do not know. It's something that human beings are reasonably good at. They have an awareness of the limit of their own knowledge and expertise. It's true, it varies from one person to another. But machines are terrible at it. Teaching a machine to know when it does not know is one of the hardest things. And the machines that we currently have, even the best of them, struggle. And you've seen this in the tendency to confabulation of large language models that is so often now talked about. So that alone is enough to mandate that there should be a person in the room.
Yeah, that's quite fair. Though I don't know whether the machine would be able to have some sort of level of confidence whenever it outputs a decision, and whether that confidence will be reflective of what is really going on.
Of course, so one of the features that we try to build into our machines is some sort of estimate of uncertainty. But the difficulty is that the whole concept of estimating uncertainty presupposes a synoptic perspective over the domain, which is very hard for the machines to acquire. This is why our focus is on, and has been for many years, on deep generative models, or models that do not just learn a decision boundary, but learn the entire distribution. They're, of course, the hardest pieces of machine engineering to produce, but they are potentially the most powerful. And as we've seen with the recent explosion in foundational models, their powers are potentially huge. But the difficulty here is that when we're presented with a problem, if we cannot already localize it to some specified domain, uncertainties will be very difficult to interpret. And the models often behave in a non-monotonic way. So as you give them instances that are more and more unusual, they may report a dissatisfaction with what they're seeing. But then beyond a certain point, they cannot say anything and may often say the opposite. They might say that actually this is a archetypal member of the class, even though this thing is completely different. I mean, an example, I mean, I know these are very naive models, but for example, if you were to take a standard classifier that distinguishes cats from dogs and give it something like a walrus, often it will say, oh, this is the most amazing cat I've ever seen. Why? Because one of the discriminating features between cats and dogs is whiskers. Cats, in proportion to their faces, have much more prominent whiskers than dogs. And so it sees a walrus and goes, oh, well, this is obviously a cat-like feature. And trivial example, of course, but the same thing is replicated in other contexts.
So you mentioned that machine will never be able to think as flexibly as the human brain does. And I was interested whether you think it will be possible in some time in the future that we'll be able to at least like model large parts of the brain, if not the whole brain.
I suppose it depends what you mean by model. If you mean that we might be able to simulate its outputs, then we're already doing very well. I mean, large language models do an excellent job of capturing logical grammar. Whatever you might say about ChatGPT and that like, they do produce pretty decent prose. It's very boring prose, but they've got the fundamental organization of language pretty well down pat. Now, there is a difference between being able to simulate the behavior of something and being able to reinstantiate or essentially replicate its fundamental mode of operation, which is effectively what a model of the brain would be. And there I would say straight away that if a model has a trillion synapses, if a brain has a trillion synapses or something like that, then the chances of building something that can model the interactions between 80 or 90 billion neurons through a trillion synapses, I think is quite fanciful. Even modeling a tiny chunk of brain is enormously challenging and hasn't really yet been satisfactorily done. It's also instructive to look at what the smallest possible functional neural units behave like when you study them. It's really interesting to read Eve Marder's work on the stomatogastric ganglion of the lobster. So she spent a large part of her career studying a system of no more than 100 or so neurons, typically fewer, in the gut of the lobster, whose only function is to make the gut contract in a peristaltic cycle. And the amazing thing about these neurons is that this network is that even though it's relatively small and even though its function is simple, the polymorphism of the system, the heterogeneity of the patterns, neural patterns that are associated with a particular behavior here, merely the contraction of the gut, is extraordinary. So the same behavior can be produced by a wide variety of neural patterns, and equally the same pattern may produce different behaviors in different animals in different contexts. So there's extraordinary complexity even at a relatively low level where you're looking at very, very small circuits. And the idea that you'll be able to produce or replicate something like this at the scale in the human brain, I don't think it's likely to happen in our lifetimes.
Fair enough. I mean, everyone knows that convolutional neural networks were inspired by the visual system that's in our brain. So I thought that maybe in a very non-distant future, not so distant, I guess, we'll be able to at least like simulate large parts of our brain.
Well, I mean, it's certainly, the brain is, of course, a wonderfully fertile source of ideas about how to create complex models. And you're, of course, right. CNNs have been stimulated by the visual cortex. But the visual cortex is an anomaly. In the sense, the organization there yes, it has some features that are likely replicated throughout the brain, but it's striking how hard it has been to get the same level of understanding of other regions. So our understanding of visual cortex is miles ahead of everywhere else. And it's probably because visual cortex is actually unusually simplified, unusually stereotyped in the way in which it's organized compared with the rest. So it may not be the right example for how the rest of the brain works.
Which parts of brain you think are most kind of interesting to study at the moment, in your opinion?
Well, I suppose everyone's interested. It's natural to be interested in the parts of the brain that are most distinctively human. How do you determine that? Well, I suppose one way is to look at what part of the brain is proportionately expanded by comparison with our nearest neighbor, monkeys. And the region that shows the greatest expansion is the frontal pole. So the parts of the brain that are right at the front. And what's striking about those regions is that, well, the damage to them can have effects that are not at all obvious if you were simply to have a conversation with someone, or even examine them, or even get them to do neuropsychological tests. So it can be quite hard to know that those regions are dysfunctional. And yet the impact that damage causes to patients' lives is profound. So, for example, one of these areas, Brodmann area 10, as it's known on the basis of an ancient classification of the cortex, none of the patients who have been described in literature as sustaining damage to those regions have ever gone back to work. And what's striking is that they fail in different ways. Some people just become disorganized. They lose their jobs because they're just unable to sequence the activities of daily life, or they are unable to maintain relationships, both professional and personal. Things start often to go catastrophically wrong for no reason that anyone can actually, no easily statable reason that anyone can give. And what this tells you is that there is some very complex aspect of behavior that's being subserved here. And that's, I suppose, the highest possible level of organization of a human being. What it is that we choose to do, how it is that we do it, and how it is that we make decisions in a way that often doesn't depend on explicit, stated, clear reasons, but actually intuitive. They're just knowing how to do things. And what's quite striking is that those sorts of abilities are often perceived as effortless. I mean, a good example of that kind of ability would be, for example, how you talk, how you navigate a cocktail party. The task of knowing when to end a conversation and start a new one and so on. We do it effortlessly, but when you think about it, it's actually incredibly complicated. Steering the conversation the right way, coming up with a phrase that's elegantly closing, and at the same time doesn't suggest to the person you're speaking to that actually you're bored of them, you need to move to someone else. So those sorts of high-level, very complex yet effortless tasks seem to depend on these regions of the brain, and finding the right way to test their function, because inevitably, if the function is complex, so must the test be, is a major challenge. But I think those areas of the brain are unquestionably the most interesting. But I should just conclude by saying that speaking of the brain in terms of areas is always hazardous, because it's a network, and really a parts-based decomposition can sometimes be illuminating, but it can also be misleading. So when we say this bit of the brain does X, we have to be careful that we don't take it literally. It's rather that the overall function of the brain may be more or less heavily weighted by the integrity of one region or another.
That is quite interesting and very insightful. I think, especially with the current knowledge of how AI operates, I feel like quite a lot of tasks we do is something that we subconsciously learned from before, and then we just automatically repeat them based on basically previous experience, something similar to what machine learning models basically do. So it's, but yeah, testing that functionality, I guess it's quite a hard task or hard nuts to crack. So going back to the clinical practice and the research, so I see that the research in this domain is quite advanced, but I was wondering how it is going in terms of like implementing all of these schemes and like practices.
Yes, so it's, I mean, if research is hard, then implementation is actually even harder. And there are many reasons for it. One is that this kind of technology is in many ways categorically new. And although clinicians intuitively feel that it's right, they intuitively feel that a model ought to be speaking to the individual patient, they obviously feel uncomfortable with not being able to understand what the underlying modeling framework is, because I mean, most of us struggle with basic statistics, machine learning. So some of it is the hesitation with anything that's new. It's also true that deploying complex models inevitably requires advanced digital infrastructure. And that's the one thing that hospitals in general and the NHS in particular do not do very well. So creating an infrastructure that can sustain this approach to modeling is a challenge. And then I suppose that the third aspect is that there's always going to be a burdensome process of regulatory approval of any innovation that has a bearing on decision making or on treatment. And this is why medicine has a complex regulatory framework, and adapting that framework to deal with some of the unusual, the unique aspects of this new technology, such as, for example, dynamic learning, that kind of thing, it is going to take some time. And although the regulators are making progress, they're making relatively slow progress. So regulation is an issue. One way of being able to draw some benefit from the technology in advance of regulatory approval is to focus on operational aspects that use these sorts of models not to determine what you do with an individual patient, but use individual level predictions in order to guide the operation of the system as a whole. For example, how the ward is staffed or how a hospital is configured. And so operational uses are actually a very important and surprisingly neglected application of machine learning. It's something that we've done some work on. The benefit there is that you can justify deployment with relatively low risk, because of course you're not using it to change the patient's management, but potentially substantial benefit, because then the hospital knows how to allocate its resources, can make some predictions about patient flows, for example, all sorts of things that currently mean that the existing clinical pathways are not efficiently implemented. And I think more attention needs to be given to those aspects, because they can give us benefits right now.
Great. Would you like to make any final remarks regarding maybe AI in neurology or AI in neuroscience or AI?
Well, perhaps the one thing to say is that for anyone who's interested in medicine, certainly anyone who's interested in the brain, complex models are unavoidable. And so if you're thinking of pursuing a career in either of these two disciplines, then you'd better start coding now. And I say this not because you're necessarily going to be a coder, not because you need to build your own models, but because you will need to have a reasonably deep understanding of how it is that they work, what their defects and their virtues are. You need to know all of that, because it's going to be not luxury exotic that some special hospitals will have as an addition to their portfolio of tools. It's going to be the bread and butter of medicine. That might not be tomorrow, might not be in 5 years' time, but that is the direction of travel. And I think we're looking at a future where hospitals will have perhaps just as much compute as they have currently administrators, indeed probably more. And that beside every clinician there will be a machine that watches over them and constantly feeds them with information, synthesis in particular, synthesize information that's relevant to the management of the patient. And understanding how these systems operate, how they can be made better, is going to be a task for every one of us. So I know it's everybody is talking about how AI is the future, but what's striking here is that it was actually already the past, in the sense that what AI allows us to achieve is what we have always wanted to achieve, which is to get to the individual patient.
Thank you so much for joining us today. It was a pleasure to have you on the podcast. Tune in to Reinforcement Talking next week to learn more about the ways AI is affecting us today and what to expect in the future.